Welcome everyone to the eMedica and MPS MSRA Masterclass for those sitting the MSRA in 2026. For those who haven't met me before, brief introduction. My name is Muhibur Rahman. I'm a portfolio GP, which means I'm a GP with different roles. I've got different clinical roles. I work as a GP, I work in community detox, and I've held various other roles before working with organizations like the Army, in secure medicine for women with significant mental health illness. My main role now is medical director of eMedica and as a consultant in medical education. So as well as running eMedica's courses, I work with various organizations within health education in England, various deaneries. We help to support their trainees doing their membership exams. And we work with organizations like the Medical Protection Society. I'm an author, having written books on MSRA, MRCGP, and GP careers. I also wrote questions for the prescribing safety assessment. I was an examiner and invigilator for the GMC, and continue to be on the examiner pool for Liverpool Medical School. I sit on the NICE GP reference panel, and our team have been helping doctors get into specialty training. We've been teaching on SJT, on MSRA, on specialty careers now for over 20 years. And we've now trained over 84,500 delegates in that time. So in terms of the format, I'm going to start with an overview of the MSRA. Then we're going to go through some exam style questions. So we'll do some clinical questions first. So you see the main formats in the clinical paper. Then we'll do 2 SJT questions, looking at the 2 sections, the 2 different types of SJTs in your paper. Then we'll look at how to make the most of the time between now and the exam. We'll start with the fact that, remember, the MSRA is not a standalone exam. You can't just sit it for the sake of it. It's an assessment that's used in part of the recruitment process for lots of different specialties. So you apply via Oriel. Some of you have already submitted your applications. For those that haven't, the applications close on the 20th of November. Okay. If you haven't submitted an application by then, you're not going to be sitting the exam in January or February. You've missed the window. Okay. And then only those that the application meets all the requirements, the eligibility criteria, and is longlisted, they'll get an invitation to book. And this year there's going to be split sittings. So if you are sitting the MSRA for GP or psychiatry, are you applying to only GP or only psychiatry, or both GP and psychiatry, and no other specialties that use the MSRA, you're going to sit the exam by default in February, sitting 2. If you're applying to any of the other specialties that use MSRA, then you're going to be invited to sit the exam in sitting 1, which is January. So those that are going to sit in January, the invitations to book MSRA are expected on the 15th of December. Those that are going to sit the exam in February, your invitations are expected on the 29th December. You should already be preparing. If you haven't started, don't worry, you're here today. We're going to do some prep today, but then from today, do something every day. Please don't wait until you get confirmation you've been longlisted and get the invitation to book, because by then it's too late. For example, if you wait till 15th December and you're sitting the exam the 2nd week of January, you've left yourself a few weeks to prepare. While you might pass, it's unlikely you're going to get a competitive score if you leave it that late. Okay, so please start preparing now. Okay, now I looked at frequently asked questions about the split sittings and about this in detail in this video. So I'm not going to repeat all of that. Please go and watch that video if you've got questions about what if I apply to this specialty and this specialty? What if I apply to a specialty that doesn't use MSRA as well as GP or psychiatry? When will I sit? All of that's answered in this video. So please watch that. Okay. We're not going to take any questions on that. We want to make the most use of the time we've got today to actually get into the exam. So let's look at the format for the multi-specialty recruitment assessment. So you're going to have 2 hours and 55 minutes in total, and that includes a 5-minute gap between the 2 papers. So both papers are done on a computer. You will sit it at a Pearson VUE test center. There's test centers all across the world. The first paper is always the professional dilemma paper. That's 95 minutes long. Then there's a 5-minute gap. Then you'll sit the clinical problem solving paper, which is 75 minutes long. Now, the 2 papers are separated and the timing is enforced. What do I mean by that? Imagine you finished the professional dilemma, the SJT paper, in 90 minutes. You've got 5 minutes spare. When you start the clinical paper, you'll still only have 75 minutes. Your timer will start from 75. You can't carry over the 5 minutes that you had left over from here and add it to that paper. They're 2 separate papers that you just happen to do one after the other, that together make up the MSRA. Now, there are multiple equated test forms. What does that mean? When you click start, you will randomly be allocated one of lots of different versions of the exam. Even on the same day in the same building, the person sitting next to you may have completely different questions to you. But so that they can compare people that sit it on one day to another, they're all equated. All the papers will be drawn from the same curriculum, will have the same proportion of easy, medium, and hard questions, and have the same proportion of questions from each of the curriculum areas, so that we can compare someone that sat it on the first day of the January sitting to someone who sat it on the last day of the February sitting. And the way that it works is they take the raw scores of everyone in your cohort, and they equate the mean score, the mean raw score, to a normalized score of 250. So let me give you an example. Let's say for round one 2026, let's say the mean score for the clinical paper is 78%. Anyone that gets exactly 78% will be given 250 points for the clinical paper. If you score more than that, you'll get more than 250. If you score less than that, you'll score less than 250. I.e., it's not just about how you do as an absolute percentage. It's how do you do compared to everyone else that sat the exam in your cohort, i.e., in this sitting. So it's competitively ranked. You could do really well, but if everyone else that sat it did better, you're going to get a below average score once it gets converted to a normalized score. Okay. And as competition has increased, as more and more people are applying and more people are preparing earlier, spending longer preparing, we're seeing that people that have done really well, it might not be enough to get an interview, or it might not be enough to get a job. So that's an overview of the actual paper. Now, every specialty has a different way to how they use your score. So first of all, let's find out, these are all the different specialties that are using the MSRA this year. Which of these specialties you're applying to? First of all, we've got some people within the webinar today for every single one of these options. All right, now, each of these specialties has a slightly different approach to how they use your MSRA, and some of those have changed this year compared to some past years. So GP, psychiatry, child and adolescent mental health, learning disability, because that's a combined application for psychiatry, CAMS, learning disability. So if you're applying for GP or psychiatry, you're going to get a rank entirely based on your MSRA score. So both these specialties use only MSRA. There's no interviews, there's no selection center, there's no portfolio. So 100% of your rank is determined by how well you do in MSRA. Obstetrics, a very small number of people that do really, really well. So last year, the top 75 scorers out of everyone that applied to obstetrics, they were able to get a direct offer without having to do the interview stage. For most people, obstetrics will just use the MSRA to decide who gets one of the limited interview slots. And once you get an interview, a third of your total rank is the MSRA. The other 2/3 is based on your interview. Okay. Broad-based training will use MSRA to decide who gets an interview. There's limited slots. Once you get an interview, though, 75% of your rank is based on MSRA. The other 25% is based on interview. Emergency medicine, it will be used to decide if you get an interview. After that, it's 40%. The other 60% is to do with your portfolio and your interview. Neurosurgery, it's 40% of your shortlisting score. The rest is to do with your application. And then overall, it makes up a third. The rest will be made up of everything else, interview and so on. Community sexual and reproductive health, it's 25%, but they first use it to decide who gets an interview, and there's very limited interviews. It's one of the most competitive specialties, about 100 to 1 last year. Anesthetics, again, it will very competitive. It will be used to determine if you get an interview, then it's 15%. The other 85% is interview and portfolio. CST, it will be used to decide who gets an interview slot. Once you get interviews, only 10%. The other 90% is all about interview and portfolio. And then clinical radiology, nuclear medicine, and ophthalmology, all of these only use it to decide who gets an interview. Once you get an interview, it carries no weight. Everything else is based on your portfolio and interview after that. But you need a brilliant score to get an interview in the first place because they're so competitive. Okay. Those of you that looked at our competition ratios video, what you realize is every specialty now is really, really competitive. There's no such thing as an easy specialty. And the recruitment team are expecting huge number of applicants this year. So competition's likely to go up even further for every single one of these specialties. I'm expecting GP to be more than 5-1 this year. Psychiatry was over 20-1 last year. Okay. So that's the exam and how different specialties are going to use your score. So the main thing is, for all of these, for GP and psychiatry, it's all about MSRA. But for all of the others, at this stage, it's also all about MSRA. Because if you don't get a really good MSRA score, you could have the best portfolio in the world, you're just not going to get an interview. And no one will be able to see how well you do at interview and have a chance to highlight all of those things. So you just need to work on getting the best score possible. All right. A common question people ask is, what do I think will be the cutoff this year? Forget that. While I can give you predictions, it could be a bit higher, a bit lower. What we know is the recruitment team are saying that they're expecting huge numbers. That's why they've arranged for the split sittings and increased capacity. So instead of worrying about what's the minimum that might allow you to get through, work on getting the absolute best score possible. Okay. For some of these specialties, you're going to need scores above 550, maybe even above 565, 570 to get an interview. All right. So you just want to work on the best score possible. So let's do some practice questions so you can actually see what it's like and we can get some prep going. So we start with the clinical paper first. This one is 75 minutes, and in that time, you're going to answer 97 questions. Only 86 carry marks. 11 questions in every paper are for research purposes. They don't look any different, so you have to take all 97 seriously. But there's 11 questions in every paper that carry 0 marks. You won't know which ones carry no marks, so you've got to answer them all seriously. There's 2 main question formats in the clinical paper. They're extended matching questions, which come in sets of 2, 3, 4 or more, and single best answer questions. Now, within that, there might be some questions where there's an algorithm and they want you to drag a label into the right box to complete the guideline. And you might get 1 or 2 multiple best answer questions where it asks you which 2 of the following are correct. And you've got to, pick not one answer, but pick 2. But the majority of questions are these 2 formats. So we're going to have a go at both of these. Now, the big challenge with clinical is that the curriculum is really broad. So these are the 12 curriculum blocks that make up the MSRA blueprint. There will be about an equal proportion of questions in each of these 12 areas, i.e., there'll be about as many cardiovascular questions in the exam as dermatology, ENT, and ophthalmology combined. About as many pediatric questions as infectious disease, hematology, immunology, allergies, and genetics combined. About as many psychiatry and neurology questions as pharmacology and therapeutics combined, and so on. So what you want to do is give time to all of these areas, because you're going to get a roughly equal proportion of questions from these 12 blocks in the exam. So what makes it challenging is not the level or the depth of knowledge that they expect in any one topic. It's just that it's such a big curriculum, because this is pretty much almost all of medicine. Anyone notice a block that you might think would be there, but that's not there? Surgery. Yeah. Do you notice that surgery or general surgery isn't a curriculum block, even though core surgical training has been using the MSRA to shortlist for a couple of years now. Now, that does not mean that there will not be any questions covering surgical topics. It doesn't mean that at all, because within the nature of medicine is things don't always fit into a neat box, okay? But within some of these areas, there can be some surgical questions. For example, within gastroenterology, you could have someone who presents with diverticulitis. You could have someone who presents with colorectal cancer and will need an operation, okay? Within reproductive, you've got obstetrics and gynecology, as well as, other reproductive, like things like fertility. That all falls within reproductive. That's a surgical topic. ENT, eyes, these are surgical topics. Within pediatrics, which is one of the 12 main headings, you could have someone who's presenting with appendicitis or pyloric stenosis, something relatively important that we see in children, okay? Within renal urology, you could have someone presenting with torsion, all right? That's a surgical topic. Do you see? So it's not that, it's just that surgery isn't a separate topic in itself, but there can be some surgically related topics where they fit within some of these domains. So let's do some questions. I'm going to do some extended matching questions first. And because you've got 97 questions and 75 minutes, you've got about 45 seconds per question. Okay, so I'm going to work to that timing. So what we'll do is we'll do a set of 3 extended matching questions. Now they come in sets. Every question and every set of questions has a title, and then you'll see the question number. Whether it's a set of 3, it will show 1 of 3, 2 of 3, 3 of 3. Okay, so what I'm going to do, I'm going to show you the screens. After 45 seconds, it will automatically move on to the second one in the set. Then after 45 seconds to the third one. In the real exam, you move back and forward at your own pace, but I want you to get used to the timing. Write down your answers at home with the question number. After we've done all 3, I'll go back to the first one and I'll launch a poll. I don't want to go through the explanation of the first one before you've seen the second one, because if I explain the first one, it might give away the answer. Okay, so here we go. First question starting now. Okay, great. So I'm going to launch a poll for each one now. I'll go back to the first one. I'll launch the poll. Please select your answer. You've already decided the answer. You already wrote it down. So I'll remind you of the scenario. So the first one, this is someone who's got stage 1 hypertension, but they need drug treatment, which suggests that they've either got established cardiovascular disease, additional risk factors, or their Q risk is 10% or more. What's important is that they're otherwise fit and well, i.e. no other diagnoses, not on any medication. And then this is one of the standard classifications that you see in the clinical record systems in the NHS for ethnicity. So the ethnicity is recorded as white British. Okay. So what's the most suitable medication to prescribe? So the interesting split, about half of you picked ACE inhibitor, but half of you picked calcium channel blocker. Okay. So the correct answer is C, calcium channel blocker. Well done. All right, so about half of you got that right, but that means about half of you got it wrong. So why is that the case? Because if you look at the guideline, step 1, when you're trying to decide does someone get an A-class drug, which could be an ACE inhibitor or could be an ARB, depending on the patient, or a calcium channel blocker, you determine this by looking at these factors. If they're diabetic, then it's always going to be an A-class drug. If they're not diabetic, then we look at ethnicity. If they were Afro-Caribbean, then regardless of age, it'd be a calcium channel blocker. This patient was white Caucasian. So as they're neither diabetic nor Afro-Caribbean, then we look at age. Under 55, it'd be an ACE inhibitor. 55 and above, it'd be a calcium channel blocker. And they're 55. And so that's why it's a calcium channel blocker. And you'll see this in the exam. One of the ways that examiners will test, do you know a threshold, is to put someone right at that threshold. Okay. So the correct answer is C. So here, this patient's 60, they're diabetic, they're already on a statin and metformin for their diabetes. They've got stage 2 hypertension, so everyone in stage 2 needs medication. And their ethnicity is recorded as Black or Black British dash African. Again, this is one of the classifications that's in the NHS ethnicity categories. Okay. This one's an interesting spread. So the most popular answer is ACE inhibitor. 57% of you picked that. About a quarter picked ARB, and about 17% picked calcium channel blocker. The correct answer here is ARB. Okay. So about a quarter of you got this right. Most people got this one wrong. So why was the most popular answer ACE inhibitor? Probably because you noticed that he's diabetic, but you might have missed this bit. This is where the knowledge side comes in. So remember I mentioned that if someone's diabetic, it's always an A-class drug. Now that's either an ACE inhibitor or an ARB, depending on the patient. If you look at the bottom part of the guideline, patients of Afro-Caribbean heritage, whenever they need an A-class drug, ARB is their first line because evidence base is that it's more effective in this group. So this patient, because they're diabetic and Afro-Caribbean, you can see Black, British, African, so African or Caribbean family heritage, then they need an A-class drug because they're diabetic, but that A-class drug is an ARB, not an ACE inhibitor, first line, because of their ethnicity. That's why it's important. That's why they've given it to you in the question. Okay. Key thing in this one is that this patient is pregnant. You can see she's picked up in a booking antenatal appointment. When do we normally have the booking antenatal appointment? So that's an appointment where generally they'll have that with the midwife. They'll check things like their blood pressure. They'll organize various tests. They'll talk to them about healthy eating, check that they've been taking folic acid and things like that. Typically happens 8 to 10 weeks. It's early on in the pregnancy, all right? And one of the reasons for that is, you might have someone who has got high blood pressure and it just hasn't been picked up. Can see at this stage, it's not gestational hypertension, is it? Gestational hypertension is when it happens after 20 weeks. At this stage, the fetus isn't big enough to be causing this. This is someone who already has high blood pressure. We just hadn't picked it up. But that's why we have the booking appointment, is to try to pick things up early. Okay. So, but that's the key thing, is that they're pregnant. You can see there's nothing else of note in their medical history. So in someone who's pregnant, that's what most suitable means, suitable for this patient in this situation. What would be the treatment of choice? Beta blocker. Okay. And well done. That was the most popular answer. So about 2/3 of you got that right. Of the rest, some picked alpha blocker, some picked calcium channel blocker, some picked ACE inhibitors. So ACE inhibitors and ARBs are not safe at all in pregnancy. They're not recommended. So they're definitely out. Calcium channel blocker, if you couldn't use a beta blocker, you might use a calcium channel blocker, a specific one, but it's not licensed, and that's why it's not the most suitable. That's a relative term, right? That's a general principle of prescribing, that if you've got two things that you can give, one is licensed for that purpose, we have study data, and one is not, you should favor the licensed one. So which beta blocker? Labetalol is first line, okay? In someone who's got high blood pressure and who's pregnant, we'd use labetalol, okay, as a first line choice, all right? If you're starting or if you're changing over. Nifedipine, which is a calcium channel blocker, if there's a reason they couldn't have labetalol, you could use, but it's an unlicensed use. And then if labetalol and nifedipine are not suitable, then you could use methyl-dopa, which is a centrally acting antihypertensive. What's not recommended at all are ACE inhibitors, ARBs, and thiazide-like diuretics. They're not recommended at all in pregnancy, okay, for hypertension. So do you see, the reason that it was E rather than C, because you can use nifedipine, is that because this is unlicensed, as you've got a licensed option here, it is more suitable than this one. And most suitable is a relative term. Okay. Good. Let's do another set of extended matching questions. This time, we're going to look at investigations. Here we go. Okay, so key things here. The age is really important here. So it's a 70-year-old patient, got symptoms that sort of fit with UTI, right? Dysuria, nocturia, urinary frequency, doesn't feel thirsty, no blood in her urine. Now, here, the key word, doing well in clinical questions, there's two things. Most of it is knowledge. You've put the hours in, you've learnt the material, you've covered the curriculum, or you haven't. But then exam technique can make a big difference. So part of that is reading the question carefully to pick up important things, like their age, like the fact that while they've got symptoms that fit with UTI, if they're not thirsty, it's probably not diabetes. Okay. And then keywords, most appropriate diagnostic test. It's not asking what would be an appropriate initial test. You might use a screening test initially, but it's asking the most appropriate diagnostic test for this patient. So the correct answer is a urine culture and sensitivity. Why not a urine dipstick? Because in this age group, you can't use a urine dipstick to diagnose. If you had a young patient, in their 20s, uncomplicated UTI, actually, if the dipstick had nitrites and leukocytes both positive, because there's a more than 90% chance that they've got a UTI, you don't actually have to send a culture. You could use that as a diagnostic tool. But there are certain groups where it's not accurate for diagnosis. So you could use it to screen, but to make a diagnosis, you need to send it off for culture. And one of those is patients 65 plus, women 65 plus, women who are pregnant, people who've had a catheter in or have got a catheter in, things like that. So because of this patient's age, we need to do urine culture and sensitivity. A dipstick is not enough to make a diagnosis. So that keyword is really, really important. Whereas, if you had a woman under 65, no risk factors for complicated UTI, then a urine dipstick, you can use that to make a diagnosis, because if they've got both nitrites and leukocytes, there's more than 90% chance that that's going to be positive. That's why the guidelines suggest there's no need to spend time sending that to culture. Just treat it. But women 65 plus, someone who's got a catheter, who's got risk for complicated UTI, like they've had multiple recurrent UTIs, you can't use the urine dipstick to diagnose. You have to send the culture off. Okay. Similarly, patients who got pregnant, who have got persistent or recurrent UTIs, or who've had a course of antibiotics and it's not resolved, you need to send a culture. Second one in the set. So here again, most appropriate test means for this patient in this scenario. So it's a 4-year-old, they've had multiple UTIs over a year and been referred to peds. They're well now. The last episode was 4 months ago. This bit's really important. So what's the most appropriate test? If we look at the guideline, it's E, a DMSA scan. Type into the chat, what's DMSA stand for? It's difficult to say, as in to pronounce. I always find it difficult, especially the second word. So DMSA is dimercaptosuccinic acid, okay? And because of their age and the circumstances, that's why they need a DMSA scan. So if we look at what the NICE guideline says on this, UTI in someone 3+. If they've got an atypical UTI, then during the acute infection, they'll have an ultrasound. If they've got recurrent UTI, that's what applied to this patient, right? Recurrent UTI, they'll have an ultrasound within 6 weeks of having the acute infection, and then a DMSA scan 4 to 6 months after the acute infection to look for, what's happening in the longer term. So do you see, because their last episode was 4 months ago, they would have already had an ultrasound scan before that, because it would happen 6 weeks after the acute incident. At this stage, what they need is this, because you have the DMSA 4 to 6 months. So do you see, picking out that one bit of information gives you the answer. That's EMQs. They come in sets of 2, 3, 4, or more. Did you see that? The answer options are the same for all the questions in the set. And you can use each option once, more than once, or not at all. So you might get a set where all 3 of them, the answer's B, or 2 out of the 3, the answer's F. It's not like I've used that option, I can't use it again. All right. That's how EMQs work. The other main question format is a single best answer, where you have a question and usually 5, but sometimes 6 or 7 options. So let's do one of those. Here we go. Okay, so, asthma is a good example of a big topic, fits within respiratory, but it's a, really common and really important condition. So expect that there will be questions to do with the asthma diagnosis and management. Now, good news is we now have one unified guideline. So we've got a combined NICE sign BTS guideline. So before there were two guidelines, so there used to be a lot of confusion. Okay, great, huge spread of answers here. I can see that this is something that some of you might not be aware of, the changing guidelines. So the correct answer is E, a FeNO of 50 parts per billion. Interestingly, 13% of you got that right. The most popular answer by a huge margin was B. This was the most popular, followed by C. Now, if you're going to get it wrong, picking B and C suggests that you actually have some familiarity with the topic. You're just not up to date with it. Okay. So if we look at the guideline, and this is taken from one of our clinical case cards, which are an efficient way to cover lots of nice guidelines, clinical topics mapped to the exam. So we're looking specifically at FeNO, fractional exhaled nitric oxide, which is one of the tools that we can use for diagnosis. So 35 parts per billion is the diagnostic threshold for children. The guideline categorizes children as 5 to 16. Under 5, we can't use FeNO. That's why there isn't a threshold for under 5s. 17 plus is the threshold for adults. Okay, so there's knowing that that's the cutoff, that's the first part of the test, because this patient's 17. They're just into the adult threshold. And then the adult threshold is now 50. It used to be 40 in the old guideline. So those of you that picked this, you just might not have read the new guideline. In the old NICE guideline, it used to be 40. In the new combined guideline, it's 50 for 17 plus. That's the adult threshold. And for children, which is 5 to 16, it's 35 parts per billion. Okay. Now, that's one of the ways you can diagnose asthma. Other ways, you can use bronchodilator reversibility, peak flow variability, direct bronchial challenge, either with histamine or methacholine, or the new criterion, skin prick testing, or IgE levels and eosinophil count for 5 to 16-year-olds. Okay, and all of that summarized in that case card. Right, last one before we move on to SJTs. Two most popular answers, actually there's three that are sort of really popular, are B, C, and E. So hyoscine hydrobromide, dexamethasone, and haloperidol. These are the three popular answers. Very few people picked A or D. Now, this is a tricky question because of exam technique. It's the first question that we've done, and the only one, that's negatively framed. And the majority of questions in the MSRA are positively framed, i.e. they'll ask, what is the right diagnosis? What is the right management? What is an appropriate treatment for this? An appropriate test for this? But you may get a handful of questions in the whole paper that are negatively framed. You can see here, it's asking which of the following would be least helpful. The word least here turns this into a negatively framed question. Now, if you miss this, and 45 seconds is a long time to read. If you're just rushing this and you thought, terminal ill patient, metastatic cancer, got nausea and vomiting. Oh yeah, I've seen in a syringe driver they sometimes put levodopa. That would be helpful. You could quickly pick that. Or yeah, I know sometimes dexamethasone can help. Someone's vomiting because of raised intracranial pressure. It can bring the pressure down. Quite useful. Someone's got brain mets, for example. They've got metastatic cancer. Okay. Cyclizine is very commonly used, isn't it? Haloperidol also can be used to control vomiting. If you missed that it was asking what would not be helpful, would be the least helpful, you could easily pick any of those. The correct answer is hyoscine hydrobromide. Now, hyoscine hydrobromide can be very useful in a terminal patient, but this patient's symptoms are severe nausea and vomiting. It will be the least helpful for these symptoms. That's because what's it used for? It's used either for bowel colic or for someone with excessive respiratory secretions to help to dry those out. Okay, so it can be useful, but for these symptoms, all of the others would be more helpful than this. Okay, and you see some of the questions like this question is very short. There's not really much information there. And you'll see that in the exam, that there's a lot of questions that are very short. There's not that many clues, but 1 or 2 clues is sometimes all you need to get the answer right. So how are we going to prepare for clinical? You want to make your learning as active as possible. Now, there's a balance. Example of passive learning is reading a guideline. So you can turn that into something active that after you've read it, you summarize your key learning points, thinking about how do I take 4 or 5 pages and write down some bullet points of the most important things. You have to really read it properly and understand it. But then what you want to do is you want to do questions. And that's why we're learning doing questions. So it makes you think, makes you have to apply that knowledge and manage your time, and that makes it more active. You remember it better. You want to allow time, and you want to systematically cover the whole curriculum. You don't want to just randomly do things and not know what subjects you haven't covered, what subjects you have, and you don't just want to do questions on things that you like. Try to practice realistic questions, and you want to work on your exam technique. So you learn to spot those keywords, to manage your time, to watch out for negatively framed questions. And you want to do timed mock exams as you get closer to the exam so that you can actually, doing 97 questions in 75 minutes is tough. And under pressure of time, you can easily miss the odd keyword, make a small mistake. It's important to remember that the questions will relate to one or more of these things. So some will be about an appropriate investigation or interpreting an investigation. Some will be about diagnosis. They give you a presentation and they want you to make the diagnosis. Some will be about emergency care. Remember, the level of this exam is the level of knowledge expected of a doctor in foundation year 2. Okay. So, what kind of emergency would we expect a doctor in foundation year 2 to be able to manage? Things like acute severe asthma, acute coronary syndrome, sudden collapse, life support, anaphylaxis, meningitis, things like that you should be able to manage. Prescribing. And then management, not to do with prescribing, because sometimes you might get a presentation and, they want to see, do you know who should be admitted? Who needs to be referred urgently because it could be a suspected cancer? Who can be referred non-urgently? Who can be managed without needing a referral? Okay. Some management might be a physio, for example. It doesn't need a prescription. All right. Sometimes it's reassurance and watchful waiting. All right. In terms of reading, the Oxford Handbook of Clinical Specialties and the Oxford Handbook of Clinical Medicine, make sure that they're the most current versions. They're useful reference sources for looking at, those 12 curriculum blocks. A lot of the questions are based on, like, the ultimate source that they use as their reference is NICE guidelines. So if there's a specific topic that you want to look up, you could look at the NICE website and look up the specific NICE guideline on it. If you want to cover a specific guideline, NICE is great for that. If you want to cover lots of clinical topics efficiently, maybe you haven't got time to read 100 different NICE guidelines, because you've got a really busy rota. What you might find helpful is our team, because people had this issue, we developed our clinical case cards, which is a way to rapidly revise for clinical exams. The questions, remember, in the exam are mapped to this. So what we've done is we've looked at NICE guidelines and we've taken things, so for example here, risk assessment for osteoporosis. Okay, impetigo, how does it present? We license this image because it will help you to visualize it. You're not going to get photos like this in the exam, but it might describe a golden crusting lesion near the mouth in a child. Okay, so non-bullous versus bullous. What would be the right management plan? And notifiable diseases. Okay, so we have a printed version, so they're handy pocket-sized cards printed on thick card. We have a digital version for those that are outside the UK. The printed cards are only available in the UK. Digital version available from anywhere, and we have a bundle where you can get the printed version delivered to you in the UK and get access to the digital version, which you can access from a phone, tablet, computer, anywhere with internet access. Okay, and what people find is it's an efficient way. So there's 112 topic reviews. So 56 double-sided cards. And then in terms of practice questions, so the eMedica MSRA question bank was the first of its kind. When we first started running courses for what was initially just a GP entrance exam, 20 years ago, there were no question banks. We wrote the first ever one. And then each year we've improved it. This year we've added another full mock. So we've now got 4 full clinical mocks, got full SJT mock, we've got timed mini mocks for standard timing and extended timing. For those, for example, someone with dyslexia that gets 25% extra, you can practice to that extra timing. We've got 2,380 plus questions now, over 2,000 clinical. It will take you about 100 hours of study to get through all these questions once. And then if you want to revise some of them that you're less confident in again, you need a bit more time. And you can subscribe anywhere from a month, which is £49, to a year, which is £129. And our clinical questions, they're mapped to those curriculum headings. So, you could work through pediatrics 1, then work through neurology 1, then work through dermatology 1, then when you finish all the ones, go to pediatrics 2 and do those questions. And so they're mapped to the curriculum. If I just show you. So within the clinical questions, can you see these are the same topics within those 12? We've covered all of them. So it allows you to do it subject by subject and make sure in a systematic way that you're covering the important curriculum areas. And once you've done that, you could then move to do some mini mocks. So there's like 45 questions in a mini mock, roughly a half a mock, okay? And do them timed, and then go through the answer and explanations after. So you get used to it. Then there's 4 full mocks. Each one of these is just like the exam, 97 questions, and each one has a roughly equal proportion of questions from the 12 curriculum bands, and it will help you to interpret your score. And when you do the clinical questions, I click one, for example, okay? You've got a title, just like the exam. You've got a question, single best answer. So, there's the options here. You pick your option. When you submit it, it will give you an answer and a concise explanation so you can read and understand not just why the right one's right, but why some of the other ones might be incorrect, so you can actually learn from it, okay? And just like the exam, there's shorter questions, but there's also some questions which will be a bit longer, okay? And our EMQs, like the exam, are 1 question per screen, you see? So you've got the options here. This is 3 of 3. When you go to the one before, the answer options are the same, but there's only 1 on each screen. That's how it is in the exam. They don't put all 3 of them on the same screen in the exam, okay? So that's our MSRA question bank, all right? You can see someone who got a fantastic score. One of the things they really liked, that it was clearly grouped by topic area, so they could systematically make sure that they're covering the topics. And, a really common feedback that we get, because a lot of people, with being competitive, will sign up to more than 1 bank. And I'd actually recommend that you use at least 2, okay? Especially for clinical. But one of the things a lot of people say after they've sat the exam is that ours is very close to the exam in terms of layout, style, the way the questions are once they've actually done the exam. Okay, so we've got 20 years worth of feedback, and every year we work on improving it. So that's the clinical paper. Let's talk about the professional dilemma paper now. So this one is 95 minutes. This one comes first in the exam. You've got 50 questions. Only 42 carry marks. The other 8 carry 0 marks. But just like clinical, you won't know which ones carry 0 marks. So you've got to take them all seriously. Now, for a lot of doctors, this is the one they find more challenging because they often are less familiar with the SJT. Okay. Within the SJT paper, there's 2 completely different sections which are marked differently. They look different. Your mindset and approach to them needs to be different if you want to do well. Okay. So section 1 are ranking questions. You get a scenario, you get either 4 or 5 options. You have to rank them from best to worst. Section 2, you get a scenario, there's 8 options. You're picking 3 from those 8 that go together to address the situation. So they look different and they're marked differently. What the SJT paper is testing is your decision-making and judgment. So it'll give you a work-based or work-related scenario, and some of those will involve a difficult situation or a professional ethical dilemma. It's not testing clinical knowledge. It's going to test you against 3 core competencies: empathy and sensitivity, professional integrity, and coping with pressure. Each of these has got subdomains that are tested in individual questions, okay? And then for some questions, so every question is going to be mapped to at least one of these. A lot of questions are mapped to more than one. They have a primary and a secondary. But some questions will also test your knowledge of core GMC guidance, ethical guidance, GMC guidance in good medical practice, things like that. So let's do an example of one. And so, section 1 are ranking questions. You'll get a scenario. It could be based in hospital, could be based in GP. A lot of them are based in GP because this exam was initially developed specifically for GP entrance. And then there'll either be 4 or there'll be 5 options. Let's say there's 5, then 1 is the best or the most effective option. 5 is the worst or the least effective. If there was 4, 4 would be the worst. So roughly, you got just over 1:50 per scenario to look at it and make a decision. So let me show you a question, and then hopefully it'll be a bit clearer. And that's time. That's what 1:50 looks like. So by that time you want to make your decision. That's because it takes a bit of time. And if I show you while you're writing your answers, I'll just show you. Because our SJT in our question bank, we built it to look and mark in exactly the same way as the real exam. So the SJT section, so our question bank includes both clinical and SJT. There's over 2,000 clinical, over 200 SJT. So the ranking ones, this is how it looks in the exam. So you've got a scenario, you've got either 4 or 5. So this one's got 4. And what you'll have is you've got 1, 2, 3, 4 in the exam. This is how it will be. And you'll have your options here, and you will drag them to the order that you want. Okay. And once you've dragged them to the order, you'll just move forward. You won't ever see your score. But when you're doing this for learning, when you check your answer, these are marked using what we call keyed response marking. So because there's 4 options, the maximum is 16. And even if you haven't got it right, you can get partial marks based on how close your answer is to the best response. When there's 5 options, then the score's out of 20. Okay. But actually dragging like this marking engine, the keyed response, is really complex. We couldn't find any commercial quiz software that could mark correctly. So in the end, we hired a programmer, I gave them a brief, and we built it ourselves so that it could actually mark in the same way as a real exam. So with these, one of the things you want to do is read the scenario carefully, try to picture the scene. Every word is important. And then it's really important to remember in section 1 that you're comparing from most appropriate to least appropriate. Okay, it's a ranking, so best to worst. So just picture the scene. You're just finishing a busy night shift, you're exhausted. The morning on-call doctor's called in sick. Now, can you see, it doesn't mention what level you are. For every one of these, you have to put yourself at the level of an FY2 doctor. Okay. As you're leaving the ward, the senior nurse says, look, while you were in the handover, medical staffing called. They said, would you stay on until the early afternoon when a locum will be available? This bit's important. You're barely able to keep your eyes open and you're unable to concentrate. So that's the scenario. Okay. And so let me just have a look at what people have put as their best response. So we've got a huge range of things. So we've got some people that would start, they've got ADECB, Some people A, D, E, B, C. Some have got E as their first option, E, D, B, C, A. Got some that have got D, A, E, B, C. Some have got D, A, B, E, C. So they've got some of the other ones around. So almost every combination has been picked. Let me show you the preferred response. Okay. The preferred response is D, A, E, B, C. Okay. D, A, E, B, C. So if you had exactly this order for this question, you'd get 20. Okay. As I mentioned, it's marked keyed response. What that means is for every possible combination, there's a number of marks keyed to it. So for example, DAEBC equals 20. No other combination will give you 20. But ADEBC will give you 18 marks, as would DAECB. Even though both of those are wrong, they're not fully correct, they're both overall quite sensible approaches. Whereas, if you had 3 right and 2 wrong, it's not that you'd get a certain number of marks every time. It's where do you have those 3? Because someone else that put D at the bottom and C at the top, they've got 3 right and 2 wrong. They're going to get a much lower score because the 2 they've got wrong are the top and bottom one. Okay, so I'm going to explain to you why this is the best response, the best order. But before I do that, let me just recap the marking. So if you get it all right, and there's 5 options, you get 20. If you get it wrong, as long as you have dragged all 5 options and put them somewhere, you'll get somewhere between 8 and 18 marks, even though it's wrong. And sometimes there's more than one combination that will give you 18 or 16 or 14 marks. Okay, there is only ever one best answer that will give you 20. All right, but as long as you don't leave anything blank, you don't leave any on the right side, you haven't dragged it at all, because if you do that, you won't get marks. If you left them all on one side, you get nothing. So like, for example, you don't get to see a question, or you skip it entirely and you don't come back to it, you get no marks. All right, but as long as you have ranked it, even if it's the worst possible order, you still get 8 marks for it if there's 5 options. Which is why one of the key things in exam technique for the SJT is just to manage your time and give each question the same amount of time. It's much better to be finished and have given each question your best go than to spend an extra minute trying to get it perfect. Sometimes to do that, you only go from 18 to 20, but at the expense of you never saw the last question, and so you lose a lot more marks than you gained. Okay. So one thing I noticed, quite a lot of you had A as your first option. Okay, it's one of the really popular ones. Those of you that put A first, type into the chat why you put A number 1. And then you might have had D number 2, you might have had one of the others number 2, but quite a lot of people I can see have got A as their number 1. Just type into the chat, share your thinking. Why did you put A number 1? Okay, great. So a couple of people have said something along the lines. Let me put them together and you tell me if this is what you're thinking. Those of you that put A, let me know if some of you were thinking, look, they've asked me to stay on, medical staffing have asked, that I just quickly let them know, look, I'm not going to do it, so they can start, trying to find someone else. And then later, I'll start contacting my boss because this is going to take longer. Are you thinking, I'd do this first, and then I'd do this next? This is the most common reason for losing marks in section 1, is that if you're thinking of these as a sequence of time, that I would do this first, and then I would do this, and then you're regularly going to lose marks, because that's completely the wrong approach. The key word in section 1 is or, not then. Each option is discrete. You have to imagine, you have to change your mindset. You have to imagine, if my whole response to this is only one of these, and I'm only going to do one thing, and I'm not going to do any other options, which is the most complete, which is the best response, mapped back to those domains. So you can see that this one, if you think back to those domains, one of the things that it's looking at is coping with pressure, because part of that is knowing your limits. Okay, can you see this? There's being tired, but there's, when you're barely able, like when you're like trying to drive and then you're not off, and suddenly you're like, I'm out of the lane, and you realize I need to stop and get a coffee, I need to have a sleep, otherwise I might end up causing an accident, right? You're barely able to keep your eyes open, you can't concentrate. Is it safe for a doctor in this state to be seeing patients? Especially, can you see, the on-call doctor is the one that's not turned up. They're asking you to cover on-call until the locum arrives. Which patients does the on-call doctor see? They tend to see the sickest patients, right? Either new patients who haven't got a plan yet, or someone who's on the ward and then they've asked you to see them because they've become unwell, right? So this is really important. You have to think or, not then. So the reason D is the best option is that if you're only going to do one of these, this is the most complete response. Why? Because do you see that in both D and A, it's clear that you're not going to stay on. All right. The difference is in D, not only are you not staying on, but you're doing something really important. One of the subdomains is that if you see a situation that's unsafe and you can't do something about it yourself, that you tell someone senior. Do you see, like medical staffing shouldn't be asking an F2 doctor who's just finishing a night shift. There's a maximum number of hours you're allowed to work in a row in a night shift, okay? And they know that they shouldn't be asking you to stay on. And what happens is they ask someone relatively junior, FY2 is a relatively junior role. Let's say that you did stay on and you were this tired and then you made a mistake. Do you think that if you got referred to the GMC, they would accept the fact that, oh, you were trying to do them a favor and they asked you to stay on? No, because part of your duty is to know your limits, right? They'd wash their hands of you and say, you chose to stay on, it's up to you, okay? You see, by just refusing to stay on, while you're not putting yourself at danger, you're not addressing the fact that they shouldn't be asking someone in the first place. Whereas if you look at this one, what you're doing here is, it's clear you're not staying on. You're letting your clinical supervisor, this means your consultant. That's just the terminology that they use in the exam, okay? You're letting someone senior who's ultimately responsible for patients and for the resident doctors in their team, their well-being, you're letting them know that this has happened. Discuss the situation. Look, doc, boss, the morning doctor's off. They called in sick. I'm exhausted. It's not safe for me to stay on. They're asking me to do this. You see, your consultant can go to medical staffing and say, you shouldn't be asking the residents to stay on when they've finished a night shift. This is not safe. You might not be able to change that, you see, because of what your role is. You can just say no. But here, you're not doing it and you're highlighting a concern about safety. That's why if this is all you do, it's the best response. It shows positives for more than one domain. Okay. Now, remember, it's or. So imagine this option wasn't there. If you could only pick from one of these, is this the best option, or this, or this, or this? Not this, and then I do this after that. It's not a sequence of time. You've got to get away from that thinking. It's a really common mistake that leads to people losing marks in section 1. So if that wasn't there and you could only do one, then you can see by refusing to stay on, you're recognizing, you're showing a positive for knowing your limits, which is the main domain being tested in. You're showing that you recognize that it's not safe for a doctor who's that tired to be seeing patients. Okay. Now, when you've got a really, generally, I recommend you start at the top and you work your way down. When you've got a really challenging question, one of the things that can happen like this is look at the top two, find the worst two, then the middle will find itself. So let's look at the bottom two. Would you all agree that B and C shows a negative for recognizing your limits and puts you and patients at risk because of this, that you're barely able to keep your eyes open, you can't concentrate, and you'll be seeing patients? Would everyone agree with that? So what makes C worse than B? Remember, section 1 is comparative. It's not just about good and bad. Sometimes they're all good, sometimes they're all bad. It's about better and worse than the one above and the one below. So what makes C worse than B? The reason C is worse than B, in both of these, you're doing something unsafe. In C, you're trying to make personal gain out of it. Because what you're saying is, I'll do a few hours, but I want you to give me a full day off back. And one of the things they ask you to do is not necessarily what you would do, but what a good doctor should do in a situation. And if you look at what the GMC guidance is, that it says that in an emergency situation, that you shouldn't try to sort of make a personal gain. You can see, like, if they said to you, look, we'd like you to cover an on-call Christmas time. It's perfectly reasonable. You weren't due to work that day. They're asking you in advance for you to say, well, that's fine, but I'd like locum rates. That's okay, because it's planned. But this has just happened, so you shouldn't try to take advantage. And so that's why C is worse than B. Both of them are really unsafe. They're both awful. But here, you've got another negative in that you're trying to make personal gain. Rather than say, I'm going to do these hours, of course, you want those hours back. You're asking for a full day off, and you know that they're stuck. So they might feel they have to say it because they haven't got anyone else. Otherwise, they wouldn't be asking you. Do you see? Now you're left with E. See, a lot of people put E higher. What's the issue with E that still brings an issue of safety, which is why it's not as good as A and not as good as D? This one's subtle. This is a very hard question, by the way, so don't worry if you struggled with it. It's just that it's got a lot of good learning points. You see, that first of all, coming back in the early evening prior to the night shift, they don't need you then because the locum will have arrived by then. But what's the subtle problem if you do come back? You might, in your mind, think I'm being helpful. If you come back in the early evening prior to your night shift, when you get towards the end of your night shift, you won't have had enough break. You work more than your maximum hours, potentially be overtired and put yourself and patients at risk. So this still carries an element of risk with it. That's why it's not as good as DNA. It still doesn't recognize your limits, which is the main domain being tested. Okay, so that's why it's DAEBC. But the key thing I want you to remember in section 1 is the word or. It's not I would do this, then this, or do this, then this. You're only doing one. That's your whole response. If you could only do one, which is the best one when you map it to those domains? Is it this, or this, or this, or this, or this? And once you understand that, you'll see why DAEBC is the best response. Okay, so that's section 1. They're marked maximum 20 if there's 5 options. Okay, so let's look at section 2 now. Section 2, you get a scenario just like section 1, but it takes much longer to read section 2 because there won't be 4 or 5 options. There will be 8 every time. And you have to pick 3 from those 8 that taken together make the most appropriate combined response. So have a look at section 2. Okay, so I've launched a poll for this one because in this one, in the exam, if I show you again how it looks. So if I just show you again for SJTs, for selection questions, this is how it will be in the exam. So you have your scenario, you've got your options, you don't rank anything, you just tick the ones you want, okay? So you don't say that A is first, D is second, there's no ranking. You just tick the 3 that you want from the 8. That's how it will be in the exam, okay? These are marked binary. You get 4 marks for each one that you get correct, okay? So, if you get all 3 right, you're going to get 12 marks. So the maximum is 12 in section 2. If you get 2 of the 3 right, you get 8. You get 1 of the 3 right, you get 4. You don't get any of the 3 right, you get no marks. So it's possible to get nothing, even if you've answered in section 2. In section 1, as long as you've answered, you can't get 0. Okay. Okay, so let's have a quick read through. Again, picture the scene. So you've been treating this patient who's diabetic and they're on the care of the elderly ward following a fall. Can you see that tells you something? Because when you read this, you want to visualize the scene, and there are some things that you can logically deduce. What you don't want to do is make assumptions, because we can logically deduce that he's unwell enough that he had to be admitted to hospital after a fall. Lots of people will have a fall and they can stay in the community because either they haven't done a significant injury or it's clear that it was just a trip. But someone that has a fall and ends up in hospital, it might be that we need to find an underlying cause why they've lost balance. It might be that the fall has, caused an injury. If it was a fracture or something like that, it'd probably end up in the orthopedic ward. But the fact that they care of the elderly ward suggests that we need to work out what's going on. And you notice an unexplained spike in his blood sugar levels each evening. Now, this is quite subtle. We can logically deduce from this each evening that on multiple days, this has been picked up, because it doesn't say one evening. So each evening, his sugars are high before dinner. You'd expect it to go up after dinner, right? And he's talked about his sweet tooth. You've seen his wife, who's visiting, give him sweets as a treat. So that's the scenario, okay? And if I look at the popular options, the popular answer options are B, D, E, G, and H. The three most appropriate actions are B, G, and H. So if you had all three of these, you'd get 12. You had any two of these, doesn't matter which two. Remember, you don't rank these first, second, third, you just tick them. You'd get 8. You had any one of these, you'd get 4. You didn't get any of these, you get no marks at all. Now, remember, section 1, it's not about good and bad, it's better or worse, you're comparing. Section 2, there are some options that they show a clear negative for empathy and sensitivity or coping with pressure or professional integrity, or they clearly go against some GMC guidance, and so you can eliminate them. And sometimes you'll be able to eliminate a couple of the options. Now you're picking 3 from 5 or 3 from 6, which is much easier to decide your final answer. So let's go through the ones we haven't picked and what's wrong with them. And then I'm going to show you a little trick you can do to know that you've got it fully right in section 2 before you actually, move on to the next question. So what's the problem with A? Why can we scratch that out straight away? Why is this not part of the right answer? Remember, we need to map back to the domains, okay? Look at the word confront. This is a patient, by definition, they're vulnerable because they're unwell enough that they had to be admitted to hospital after a fall at home. Does it show a positive or negative for empathy and sensitivity and professionalism to confront a patient? It's not even about the patient's behavior. There might be some situations, let's say a patient was hurling abusive language at one of the staff members. Actually, a confrontation might be appropriate. But is there ever a situation it's appropriate to confront someone about someone else's behavior? No. That shows a negative for empathy and sensitivity, a negative for professionalism. So we can clearly get rid of A. What's the problem with C? Goes against making the care of the patient our first concern, which is part of the duties of a doctor, right? That if on more than one occasion, because each evening there's an unexplained spike, if we just monitor it less frequently, it doesn't mean it's got better. It just means that we won't know about it, and it might take longer before it's picked up. They might get more unwell and no one knows about it. So this isn't in the patient's best interest, so we can get rid of that one, okay? I'll come back to D and E because, quite a few people actually picked one or other of those, okay? So I'll come back to those, especially a lot of you picked D, about half of you picked D. But F, hardly anyone picked. So what's wrong with F? 2 things wrong with it. One is, it's just not your role. So you as an F2 don't get to decide visiting times and who can visit how often. Generally, that's not something clinicians decide. Sometimes a consultant might make a decision that for a particular patient, they need their rest, they're getting too many visitors, they might do that. But generally, who would decide visiting times and who could visit? It's generally the senior nurse on the ward, ward manager or matron, okay? Not an FY2. So this is just not your role. But also, the patient might really like to have his wife come and visit him. If you think about their overall well-being, they're in hospital, it might cheer them up to have, a family member come and visit them. And so this doesn't think about the patient's feelings. So it also shows a negative for empathy and sensitivity. Now we're left with D and E. Quite a few people picked one or other of these. What's the problem with D and E? It's the same problem for both, actually. It's confidentiality. Do you see? If you drop by while his wife is visiting and discuss his care and recent results with both of them, in none of the options have you sought his permission, his consent to share. Someone's results are confidential. Just because it's his wife doesn't give her any automatic right to have access to his results. It's up to him if he chooses to share. And if you just start discussing, can you see, in none of the others have you got the option where you've sought his consent. Similarly here, discussing the results with the wife, that breaches confidentiality. Okay. Now, let's have a look at how you can know you've got the right answer. And that is that if you read back the three that you've picked, it's not necessarily in alphabetical order, but if you read them back, add in the word and. Does it make sense together? Because remember that section 2 is the most appropriate combined response. Sometimes you could have three things that are all sensible, but they don't go together. They are not the right answer. So remember, section 1 is or, section 2 is and. So does this make sense? This is the scenario. Does it make sense? Picturing the scene really helps. Discussed recent blood sugar levels with Mr. Jackson. So Mr. Jackson, just to let you know, in the last few days, every evening I've noticed your sugars are a bit high before dinner. I can't really explain it. And explore is that. Just trying to work out why it could be. Talk me through, what did you have for breakfast yesterday? And what about lunch? What about dinner? Did you have anything else? Any snacks, anything extra? Just explore his diet. And, well, look, here's some sugar-free treats. You know, you've mentioned that you've got a sweet tooth. These things, it might give you the taste that you're looking for, but they don't actually have sugar, so they shouldn't impact your sugar in the same way. And continue to monitor his sugar levels at least daily, because each evening suggests that at least you've got one reading each day, but at least continue to do what you're doing, if not more. Together, does it make sense? Yes. Together, does it give a response to this that's sensible and better than any other combination of three? Yes. That's how you know you've got full marks for it. So that's how you'd get 12 out of 12. Okay, so it's B, G, and H. Okay. So remember, for selection SJTs, it's just 4 marks for each bit that you get right. Okay. If you get all 3, you get 12. Any 2, you get 8. Any 1, you get 4. There's no negative marking. You know, you're not losing marks because you got 1 wrong. You just don't get the marks. And the key thing to remember is and. Does it make sense together? Okay. And it doesn't have to be in alphabetical order. You're not ranking 1, 2, 3. You're just picking the 3. Okay. So how do you prepare for the SJT? Very different to the clinical. Because the clinical is 90% knowledge, 10% technique. The SJT is almost the opposite. It's 90% technique and 10% knowledge. So you want to know the 3 domains, but you also want to know the subdomains. So each of these domains have got multiple subdomains. They're broken down into little things. Each specific question will have a primary domain and some subdomains that are being tested in there. They'll often have some secondary domains. Okay. So, you know, the one we just looked at here, this one, it's not really testing knowing your limits. What it is testing is professional integrity, so knowing the rules about confidentiality, then empathy and sensitivity. You know, how would he feel you confront him about his wife's behavior? You see, that links to empathy and sensitivity. Okay. Part of professional integrity is knowing the rules about confidentiality, respecting patient confidentiality, knowing when you can and can't breach confidentiality. Okay. Read good medical practice and the core GMC ethical guidance, because for some questions, these things will really help. It's not necessary for some questions. These are necessary for every question, because every question maps back to them. You need to understand the difference between questions in section 1 and section 2, because what they're asking you, and therefore your approach and mindset and how they're marked, is different. Then you want to practice questions to time. Now, for the SJT, actually, if you practice lots of questions from lots of different sources, sometimes you get confused and it makes you worse. Clinical, I would always say, do thousands of questions. Finish all of our questions, get another question bank, do another couple of thousand questions. Okay. For clinical, we know this, that volume over time, you will have covered the curriculum. With the SJT, it's better to practice a decent number of high quality questions and spend time understanding the why than just doing lots and lots of questions, especially if some of them start causing you confusion and then you sort of get analysis paralysis in the exam and you're stuck because one bank says something completely different to what you learned in another one, and then you don't know where to go. In terms of the core ethical guidance from the GMC, things that are relevant to your exam and you should learn. The biomedical ethical principles, autonomy, beneficence, non-maleficence, justice, confidentiality and the rules around that, capacity, advanced refusals, do not attempt resuscitation orders, the difference between Gillick competence and the Fraser guidelines and when they apply, consent, understanding Bolam and the Montgomery case and how that's impacted that, and Bolitho and the new GMC guidance on it, personal beliefs in medical practice, both for doctors and for patients, financial issues, raising concerns. We had one of the questions around that, safeguarding adults and children. And, I talked to you earlier about our question bank. So our question bank has both clinical and SJT. If you want more than that, if you found the teaching and the way we've covered questions and topics here helpful, then what you might find really helpful is our 2-day MSRA grammar course bundle. So we have a full day of clinical. We'll go over 100 clinical topics, more than 130 questions throughout the day. We have a full day on the SJT. We'll go through 40 SJT scenarios. We did just 2 there, okay? We'll do 40 in detail, but we'll also cover all of the key ethical guidance and GMC guidance that you need to know relevant to the SJT. We've spent hours going through it, and then we teach it in a concise way so you can learn it efficiently. We also cover exam technique for both papers. For both papers, it can make a big difference. For clinical, we'll cover higher clinical topics. We'll cover things from all of the 12 curriculum headings, and you'll do time teaching mocks for both papers. We've had excellent feedback for over the last 18 plus years that we've been running it. All the questions in the grammar course are unique to that course. They're different to the ones in our question bank or that you'll find anywhere else. They're different to the ones that we've covered in this session. And if you book the live sessions, which are running on the 29th and 30th of November, you can also get access to the recording. So with the standard ticket, recording for 1 month. With the extended ticket, you get access for 12 months. Either ticket gives you access to the question bank until the end of February. So the live sessions, 29th and 30th, it is possible just to book one day or the other. So if you just want to attend the clinical day, that's the Saturday. If you just want to attend the SJT day, that's the Sunday. If you're only booking one day, you'd have to book the question bank separately. If you book the 2 days, you get access to the question bank included, okay? And something else that we're running, some people don't need 2 days. Some people might feel they haven't got time for that. They might want something that is more concise. We do have this year a new course, our MSRA High Yield Booster. So that's going to run the 16th of December. It's a long evening, 3 hours and 15 minutes. So we'll do 10 SJT scenarios in depth. We did 2 today. We'll do 20 clinical questions spread across the 12 curriculum domains, and we'll go through the relevant NICE guidelines. So it's a quick, efficient way to consolidate key knowledge. It's £125 is the standard price for that. If you book by early December, it will be £100. This is already significantly discounted compared to if you were to book day 1 and day 2 separately and pay for the questions separately, okay, and get access to the recording. One of the things that this course gives is it allows you to cover a lot of topics in an efficient way, okay? This is the recordings that you get access to afterwards. But I think particularly for the SJT, going through the reasoning and understanding the why, for a lot of people, it's made a significant difference. Okay, I'd say there's probably 5 groups of people that it's particularly helpful for. So let's say you've already started your preparation, but you just want a boost because you just want to get the absolute best score possible. You're aiming for 575 plus, 600 plus, because maybe you're applying for a really competitive specialty or a really popular area or both. You want ophthalmology in London. You want core surgical training in Manchester, both a competitive specialty and a competitive area. And so that even 1 or 2 marks could be the difference between you getting an interview and not. So that's one group of people. You've already started, you've done some, but now you want a boost and you want to cover a lot in an efficient way. Another group is people who maybe haven't actually started. And so you're starting quite late, really. But what you want to do now in the time left, you want to cover a lot of topics efficiently for both papers to maximize what you can achieve in the time that's left. Another group is those that maybe you've actually sat the exam once, twice, more than that, and you're resitting and you realize, look, I need to do something different to what I've done before. Maybe you've just relied mostly on question banks and reading before, and you think, actually, if I get some teaching and some guidance, and I want to significantly improve my score. And the last group is people that find the SJTs challenging or just aren't that familiar with SJTs, and you really want to improve your understanding and approach, which sometimes just doing lots of questions won't give you. Once you understand how to map to the domains, what all the subdomains are, the sort of approach, and then go through detailed discussions of multiple scenarios, then you can apply that to any question you get and you fly through. And we've had all of these categories of people that we've helped. So here's someone 618, 315 in clinical, 303 in professional time. They ranked second in the whole country for psychiatry. They got a CAMS post in Maudsley. They also ranked fifth in the whole country for GP. That they took the CAMS post up. Here's someone that got 552 for anesthetics, didn't get in that year. So this is someone that's clearly prepared well to get a score like this, a good score. Came to the course, went from 552 to 625. After interview, they ranked sixth in the whole country, got their first choice area, anesthetics in London. Okay. Here's someone, they already actually were very keen, hardworking, made a start early, but they just weren't familiar and confident with SJTs, and they wanted to change that. And what the course really helped them with is going through the in-depth explanation to change their approach to SJTs. And they could see then when they did questions going from low 3 to a band 4, they actually scored 623. Top 1% in the whole country. Okay. Here's someone, again, they found that the professional dilemma section was really helpful to demystify. They got a framework for it, got their first choice GP offer. Again, they did the MSRA 2 years previously for obstetrics. They then decided to leave that and reapply to GP. So when they got into obstetrics that year, they had 540, which was enough for interview. They did really well at interview, but they went from 540 to 610. Again, it's a huge increase because it's harder to make such a big increase when you've already got a higher score than it is when your score's under 500. Much easier to add 70 at that point. Here's someone, 604 for GP. Again, this person got offers for radiology, GP, psychiatry, and obstetrics. All right, 579. So how to prepare effectively for both papers. So let's look at first common reasons for not getting the score that you want, for getting a low score or a score that, while in past years would have been good enough, isn't enough now with the levels of competition to either get an interview, or for GP and psychiatry, which have no interview, to get an offer or to get an offer that you want, and you know how to avoid them. The first one I'd say is just not allowing enough time. I think a lot of people, they maybe talk to friends who got in a few years ago, did only a couple of weeks of preparation, but there was a time where you could get into GP with a score of low 400s or mid 400s, okay? Or you could get an interview for some of the other specialties with low 500 and something, 520. Those days are gone, okay? And so as a result, the earlier you start, and then once you start, if you do something every single day, just be consistent, all right? What that allows is that it allows you to systematically cover the whole clinical curriculum, allow time for you to understand the SJTs, to read the relevant guidance, to do questions, to then revise as well, not just to have gone through it once, but revise the areas that you're less confident in. But it also allows life to get in the way, because sometimes you'll have, like I just recently recovering from COVID. I've still got the cough, but I was completely out of it I lost a whole week. I had lots of plans of things I was planning to do. If you start early, you could have a period of illness and you'll still be on track because you've built in a bit of a buffer, okay? Underestimating the exam. I think sometimes people, they treat it like exams that they've done before, like say PLAB or finals, UK MLA, where even though those have large curriculum, because they're pass-fail exams, no one cares what you score. As long as you pass, it's fine. Nearly everyone passes the MSRA, but passing isn't enough. You're competing against thousands of other people, do you see? And actually, in the case of GP, not just thousands, tens of thousands, okay? 16,000 odd people ranked last time, 21,000 actually applied, right? Because not everyone passes. So, it's competitively ranked. It's not just about passing. You will pass, but most people pass, most people don't get an offer, right? You want to be at the top. It's competitive. Focusing on just one paper. So I've seen people who just treat the SJT as an afterthought. They get band 4, really good score in the clinical, but they get a really poor score, and overall it drags down their score, and it's not enough for them to get an interview or to get a job. Or the other way, I've seen it the other way. People have done really well in the SJT. They just didn't allow enough time for the clinical, and their clinical score dragged them down. Remember, they're both equally weighted in that original ranking. Finally, poor exam technique. So, for clinical, understanding and learning the keywords, practicing your time management. For the SJTs, time management is really important, but also understanding the approach to different types of SJT, learning to map to the domains and subdomains. And that's what the course will give you. So how to prepare effectively? The opposite, if you like, active learning. Actually make sure you're applying the knowledge that you've read. So I'd recommend for clinical, you expose yourself to at least 2 question banks. So, if you're going to use ours, do another one. Doesn't matter which one. You could use Past Medicine, you could use MCQ Bank. There's lots of different things out there now. But just exposing yourself to additional clinical questions is useful for you to have made sure of actually understood the subject. Okay, but you also want to do some reading. So, reading up, when you get a question wrong, reading up beyond just that explanation, reading the guidelines, you get a deeper understanding. You want to cover the curriculum systematically. So this is where our question bank can help you. Make sure that you systematically go through all the topics, then do the mini mocks, then do the mocks. You build up, because in the mini mocks and the mocks, you get questions from all topics. Okay, and all those questions are different to the ones in the sections. They're not repeated. Our mocks are all unique. That once you start, and hopefully you've already started, but if you haven't, you've started today. We've spent an hour and a bit already together. We're coming to the end now, learning. But then just learn something every day and set some targets. Maybe 60 minutes or an hour and a half if you can each weekday, a bit more on weekends between now and the exam. Those of you sitting in January, we've got a couple of months left now. Okay. Those of you in February, okay, you've got 3 months. Okay. Try to practice realistic questions, work on your exam technique. And one of the things that can help you with that is to do timed mocks. So you get used to managing your time. Finding a study partner or a small group. Okay, what I mean by small is like 2 or 3 people to encourage yourselves that, look, let's all do the cardiovascular 1 questions, then we can discuss any, or let's do SJTs together and we can discuss it. Not a huge group. What I've found when people form a really large group is you get a lot of people, they go into side chatters, you lose a lot of time. It's not actually that conducive to learning, but having 2 or 3 people for accountability. Have you done your set of questions today? Did you read your guideline today? That can be really helpful. Or 1 study partner, that can be really, really helpful. Things that you might find helpful, we've got a group specifically for GP training. It's over 47,000 doctors, and that's the largest group for GP training anywhere. We've got a group for MSRA, which is for any specialty that uses the MSRA, not just for GP. Okay, so you could join both of those. We post updates and you'll see people answer questions there. And I already told you about our MSRA question bank, which is available on its own. Or if you join the MSRA grammar course, that includes a question bank as part of that up until the end of February. Okay, we do also have, if you're not available on those days, you will get access to the recording, but you can also just subscribe directly to the recording. So on the eMedica website, we've got a section for MSRA, but you can also see the advert for it there. So this is the MSRA Cram Course bundle. So if you just book the clinical day, it's $250. If you just book the SJT day, it's $250. So just those 2 separately would be £500, and that doesn't include the question bank. The bundle is less than that, and it includes a question bank and the recording. Standard ticket for a month for the recording, extended ticket, the question bank and the recording for a year. Okay, so that's the 29th and 30th. But you can also just directly subscribe to the recording. So if you were to subscribe now, you'd get access to the current recording, which is from last year's course. It will automatically update to the new recording within about a week of the live session. Okay. This doctor got into emergency medicine, ranked 7th in the country, 610. If you're already using the eMedica question bank, we sent you an email so you can get a discount to upgrade to the full bundle. If you are a member of the Medical Protection Society, they will have sent you an email with a code where you can get a discount either for the question bank or for the MSRA grammar course. Okay, but I'll just leave you with a couple of other messages. ACCS anesthetics, 6th in the country. This is one we already had. They found it particularly helpful for the SJTs. This one again, they got their first choice radiology training. Actually, this person now is, progressed in their radiology. This person is an international graduate, got into ophthalmology in London, one of the most competitive specialties in the most competitive deanery. Okay, and again, they found it helpful. And then we've got our 2 blogs, gptraining.info. There's articles from people who've scored over 610. And the eMedica blog has also got articles from people who got into anesthetics, surgical training, which also talks about the interview, the next step beyond just the MSRA. But there's also tips on how they prepared for the MSRA there. Okay. So before we wrap up, and I'll take questions now, do follow us on social media. So we're on Instagram, YouTube, TikTok, Facebook. Do join the support groups for MSRA and GP training. Do subscribe to the YouTube channel because I regularly post videos, if you want to keep up to date with what's happening for specialty training. Okay. So let me summarize. Look, this is a two-part assessment. They're equally weighted. Whether you get an interview and then ultimately your overall rank for most specialties will be impacted by MSRA. For GP and psychiatry, it's just your MSRA that will determine your rank. And it's not a simple pass-fail. Just passing isn't enough. It's competitively ranked. It's how you do compared to others. So fight for every mark, because one mark could be the difference between getting your first choice job and a lower one, between getting a job and not getting one, between getting an interview and not. But if you focus your revision, you practice under time condition, you make the days between now and the exam count instead of just counting the days. Okay, Muhammad Ali said that. Don't count the days, make the days count. Then you can do it. And I'll leave you with these two messages. From Michael Cordo, who said, to succeed, we must first believe that we can. Don't be put off by the fact that the competition ratios are what they are, because that's not something in your control. What is in your control is how hard you work for it. So if you first have that thought, look, someone's going to get in. Yes, it's competitive, but it's competitive to get into medical school. You fought people off. You're intelligent, you're talented, you're hardworking. You've got to where you are by having those traits, okay? So if you first have that faith that, look, someone's going to do it, it's going to be me. I understand it's hard, but I'm going to put the hours in. I'm going to do the work. If you have that belief, it will help you to stay motivated and put the hours in, because it is hard. And the second is from Malcolm X, who said that the future belongs to those who prepare for it today. So, you've taken a good first step today. Hopefully now got a clear idea of what to expect, the different types of SJT, what the curriculum is for the clinical. You've seen some of the questions and some of the things. Now you've got to put the hours in. Go away and do the work. If you give it everything that you can, if you put the hours in, you do everything that's within your capability. If after that it's not meant to be, then it's not meant to be. There's always next year. If something's meant for you, the whole world can't keep it from you. And if something's not meant for you, the whole world can't bring it to you, okay? Whereas if you didn't put in the effort, you didn't take it seriously, then you might wonder, actually, if I had sacrificed, going out that couple of evenings and doing a bit more work, or if I had decided to, give up a bit of my weekends and give up some of my time because I know it's competitive, maybe I could have got the choice of specialty I wanted to. If you put these things together, have that first start with that positive attitude that, look, I can do this. I know it's hard, but I can do it. And then put the hours in. Do everything you can. And then if you want support, we've got multiple courses. We've got things. We've been supporting people for 20 years now. Okay. It's there. Some of you might not need it. Maybe you've already made a start. You've been preparing for a couple of months. You've got a good handle on SJTs, on GMC guidance, on NICE guidelines. And you just need some questions. You might just sign up to the question bank. You might use a case card. Others, you might benefit from that additional support and, make that investment of time to actually squeeze out every mark that you can. Okay. So whichever you choose, whatever specialty, put in the work, prepare, and you will succeed.